she had said to me that one of the hospital leaders made the comment, we trust our gut to identify who is an appropriate participant during the interview process.
Oh, God.
And that just as, I mean, I'm sure you all understand how the way that struck me, given what we do.
Yeah.
And I just wanted to share that in talking about hospital leadership taking on the role.
Wow. I'd just like to say that probably the next word out of Evan's mouth will be dude, something, something, something. Just
Actually,
based on history.
I was going to say that I got a temporary license in Delaware in approximately that way in 1988. But this is not 1988. There are rules. It's a good reason that there are rules.
Okay. Any further discussion before we have a
Well,
vote?
I just want to say something. Hospitals are so desperate. This is the problem. They're so desperate to get more physicians. They'll say almost anything, or believe almost anything. This is the problem. Desperation causes bad decisions.
Yeah.
And
Dude.
from the very beginning, our biggest concern has been quality, making sure that these folks have the training, which we cannot vet. So we can't do it, but others, I believe, those people who are in favor of it. I mean, there's reasons why they're in favor of it, but not necessarily good.
Okay, how about we vote on this measure? All those in favor of proceeding with this measure, basically opposing the legislation as written, all in favor say aye.
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 Any opposed? Any abstentions? So Ron, let's just make it clear that it was a unanimous decision, please. Okay, let's move on. We had two other topics we wanted to discuss. Probably the CRNA comes first. Is that right, David?
Yes, I had shared with Matt that I got an email today from the Medicaid director who is also involved with the process because it's a CMS payment issue, and saying that they intend to go forward with this and implement it in the middle of February, and that they need to consult with the board, and didn't really ask for consultation, but just acknowledged they need to consult with the board. And I said that it was on our agenda for today, and I'd be getting back to them about the CRNA change. And I apologize. I sent out a really late email today.
Yeah, I didn't
I
read it.
attached and it was not a medical journal article. It was the Journal of Public Economics. And it's the best study I've found so far addressing these issues. And I felt somewhat better. I was feeling really, really defeated when I saw the email from saying that the decision had basically already been made. But I felt heartened when I read this article, because what they found and what seems to me really well supported research is that the the change in the CMS billing policy hasn't changed behavior. They said it's like all the positions that the advocates are taking on both sides are unsupported by the data, basically. That the CRNAs are not moving to states where the opt-out has occurred, that the amount of supervision taking place, whether the opt-out has occurred or not, basically stays the same. Their conclusion is that there are a lot of other factors in play, And I don't know what you want to do with that information, but that was, I sent out an email late this morning with a few key quotes. I don't know if anybody had a chance to see it or read it. Let me pull it up right now. All right. Yeah, I sent it at 10:22 today. Some of the comments, the first one I shared was about CRNA utilization. They said, in contrast with some policymakers' expectations and overarching goals, we find no evidence that CRNAs are utilized to a greater degree once their supervision requirement is repealed. The next thing I noted was they said, also on page 3, that CRNAs do not make decisions about where to practice based on whether a state opts out. And that the quote is, descriptive long-run evidence discussed in section 5.2 likewise does not indicate that CRNAs are disproportionately seeking out work in deregulation states, even many years after the shift to a more favorable policy environment. The third point that I shared was that there's a lack of support and data for advocates' arguments. On page 4, they said, our results do not reveal that deregulation is necessarily harmful, but the assumed benefits may be slow to materialize and possibly non-existent. And also on page 4, they said the proponents and policymakers encouraging these regulatory changes view the CRNA supervision requirements as either restraining beneficial provider substitution, interfering with optimal labor allocations and medical care productivity, or both. Our findings, which are based on states that removed the CRNA requirement in earlier years, cast doubt on the anticipated policy impacts for these recently deregulated states. And then they did look at some other studies and made the additional observations. Based on descriptive analyses, CRNA-only staffing models are not more common in opt-out states in the cross-section. They also noted that the authors of another study do not detect faster growth in anesthesia services among states taking advantage of the Medicare opt-out rule. Growth in non-opt-out states actually appears to outpace growth in opt-out states in this regard. And also, in another study, they also observed no change in travel distances for several prominent surgical procedures for Medicare beneficiaries. And that relates to one thing that has been looked at over the years is whether patients had to travel further because of the in the states that had not opted out. And they found that the data did not support that conclusion. So I don't know what you want to do with it. If you, I was hoping, is Margaret Tando still on? I was really interested in hearing a surgeon's point of view on this, about the idea that a CRNA supporting a surgeon or Dr. Odeji also, if a CRNA supporting them is not under a physician supervision, does that concern you? And
so actually that article is very interesting and it makes sense that there is no benefit. So it does really concern me. The reason why is that if it's just a CRNA and there is no anesthesia or any surgeon, they actually do less risky cases. So the type of cases they do is very as basic as possible compared to if just like an MD anesthesia supervising them. So they have like a cutoff of, if you have like a significant cardiac history, they tell you to go somewhere else where they have like an MD anesthesia to do those cases. So that's why there's kind of less risk with the CRNAs without medical physicians.
Before we go on, I just want to clarify whether you need a motion from us, David, or we're just looking for discussion. What,
I
you
would
need?
want to have a motion because I need to give input to the governor's office.
Okay.
And saying, the board supports or does not support this.
Okay. Dawn?
Well, I just want to clarify, this is not a bill yet. Is that correct, David? It's just a policy discussion
This is
right
not,
now?
this is not going to have to go before the legislature.
Okay.
So there's, since 2001, there was some delay in implementing it, but the regulation was changed in 2001, saying that states that want to opt out can opt out, and that's it's just a choice, and it says that the governor can ask to opt out. They have to consult with the boards of medical practice and nursing before doing so,
Okay.
and just submit a letter. It's pretty simple.
Thank you.
Evan?
I make a motion that we oppose the change. I have two reasons for that. The first, I do interact with the nurse anesthetists and anesthesia assistants, who are basically like PAs of anesthesia, and anesthesiologists quite a lot, because I do ECT 7 days a week, 7 days a month, not 7 days a week. I have done that, but 7 days a month. And have done that for many years and have seen this play out. To my eye, the division of labor and supervision, the way that it is, works well with the CRNAs and anesthesia assistants doing the less complex cases, and the anesthesiologist being immediately available for supervision if there's a complication. And I don't see a reason to change it. The second reason is that we are missing at this point a lot more input regarding pros and cons, but I haven't heard anything that makes me think that we should change it. And the way that it is now works well. I'm concerned hospitals are constantly under the gun to cut costs. And I'm concerned that this is another instance in which, if there is not a requirement for a supervising anesthesiologist, there will not be one. Maybe not this year, maybe in 5 years or down the line. But when there's an economic incentive to not do something, hospitals tend to not do it, is my observation over 30 years of working in hospitals.
Okay, thank you, Evan. So just to clarify where we're at, we have a motion. Do I hear a second on that motion to oppose this matter, understanding it's not legislation?
I'll second it, Philibert.
Okay, so we have a second. So I'm going to move to discussion about the motion on hand. And I'm going to jump ahead just for a minute, because I did, since David and I talked, I actually got an email from the president of the Vermont chapter of the American Anesthesia Society. And they are also opposed to this measure, probably predictably, but they are opposed. And they actually, she made the exact same argument that Evan just made, which is the system that we have works well. It's a triage system where less complicated patients are seen by the nurse anesthetists, and then there's some backup available. I have a few other comments, but I'm not going to jump ahead of everybody. I just wanted people to know that I have gotten that feedback and share that with you. David, I think Coder is next.
Yeah, I think my question is, do we have a problem in Vermont with this? And I believe from the readings that critical access hospitals don't necessarily have to have an anesthesiologist physician supervising. Is that correct,
Right.
David?
They don't need to have an anesthesiologist standing by. It can be technically the person performing the procedure can be supervising them.
The
So
surgeon. Yeah.
they are subject to the physician's supervision.
Yeah. So, yeah, I would also be opposed to this since I don't see it as a huge problem in this state.
Stephanie?
I was just wondering if the more rural hospitals would be, but perhaps the discussion previously answered my question, would be more inclined to be in favor of this type of deregulation because of the cost, and does that affect the patient care? If a less qualified individual is participating in a complex case. Can someone answer that?
I can speak at least from my observations here at Copley Hospital in Morrisville. There is no anesthesiologist on staff. CRNAs do all the anesthesia. Some cases are referred out because of risk factors. That's for sure. And I'm frankly not sure what I believe the surgeon is actually the supervising physician. That was kind of why I asked that question about critical access hospitals. If there's something about them that does not require supervision, but it works well at Copley. I can say that.
I think David Codere, you're correct. If under the present, without the opt-out, the person performing the procedure is supervising them technically.
Bob?
Yeah, I just wanted to say that we have the same situation in Brattleboro where we have no anesthesiologists on staff. And it has been working well in our hospital. And I guess the supervisor would be the surgeon, I imagine. But I also wanted to ask if Peter Ireland, who has been so involved in this, has gotten any feedback from anybody or anything to add to what we're already saying.
Not this part of it. I haven't been involved in the CRNA bit. The transition to practice, I'm more involved outside.
All right, thank you.
Ian?
So that was the point. I was just trying to clarify that usually, I think for Vermont, the surgeon performing the case is the supervisor for the CRNA. And most times, my point was that the CRNA kind of knows more than sometimes the surgeon performing the case. The only person that knows more than the CRNA most times is the anesthesiologist himself. So that's why it's like the opt-out doesn't really matter to Vermont per se, because if it's not an anesthesiologist, MD or DO, oftentimes the CRNA it does more intubation, than the surgeon doing the case.
Evan?
Can you guys hear me?
Oh,
Yeah,
Margaret's
Margaret?
talking.
Faintly, Margaret.
Can you all hear me at all?
Now,
Yeah.
yes.
Okay, I have a technical issue, so I didn't hear a lot of the discussion, and so for bills to vote on, I cannot vote on it. But I wanted to ask, who takes care of the complication? And I wasn't clear on what the opt-out, what the whole thing is. Is it that CRNA doesn't need supervision? And if there's a complication, who takes care of it?
The CRNA. They don't have a supervisor.
Yeah, and
The issue we have here at UVMMC is there are a lot of cases that need to be done, and then we get it transferred in because the CRNA or whoever decides, well, this is too complicated to take care of in a little critical access hospital, which is understandable. But then you can also use that as being on call and sending every case away because finding a reason to not operate on them because it doesn't, because you're not comfortable. So that's another side of all of this equation. The other thing is I haven't heard any pros and cons. I haven't heard from the anesthesiologists. I haven't heard from the CRNAs. It's just something I missed. I read what David had sent out earlier, but This is a discussion that I would like to kind of understand a little more.
Thank you, Margaret. Evan?
So yeah, so that's what I said,
Yeah.
because I'm at a critical access hospital in Springfield, and most times, if the cases are complex, when they come to the ED, they just send them straight to Dartmouth anyway. So that's what I'm saying. I don't think it makes a difference per se, because the CRNs are very selective on the cases they do.
It does make a difference though, because it makes a difference at the receiving hospital, in that I'm totally fine if a critical access hospital triages what they will keep and operate on site and what they will send. But what this bill would do, or if it becomes a bill, would be that it would mean that there did not have to be a supervising anesthesiologist at UVMMC either. And I think that would be a huge problem. You know, we don't have anywhere to send people unless they're going to Boston. And so, you know, the system, the way that it is now, works fairly well. But I think that that removing the supervisory requirement everywhere, including at the receiving hospitals, would be problematic. And I don't think that that would happen immediately, but over the next few years, the economy gets worse. You're the CEO, you're looking for somewhere to cut. It's perfectly legal not to have the anesthesiologists lay them off and get CRNAs.
Matt, if I can
Yeah,
respond
David.
so one thing I've learned in preparing for this is that and again, we're talking just about Medicare billing. The procedures are billed based on the procedure and not on who is doing it. It's so there is effectively no savings. If there is a supervising anesthesiologist, it's split between the supervising anesthesiologist and the CRNA. If it's a non-anesthesiologist, surgeon is, or other person doing the procedure is not a surgeon, they don't split because there's a rule about you don't get paid for two different roles at the same time in the Medicare billing rules. And so one of the things that they pointed out in that article is that there's no monetary change. It doesn't really change the cost. There's no noticeable change in the cost.
I don't think that's right. I'll put it in the chat. I'm sorry.
And the other thing is that they did find in this study that there's, and I think for the reasons that were just pointed out, about the CRNAs self-opting out of not taking cases that are complex, the authors of this study I sent out today said that the amount of supervision going on is the same in the opt-out states as it is in the non-opt-out states, that there are other forces at play that are driving the decisions in this regard, and it really hasn't made a difference. It seems hard to believe, but that's what they said that data is. And they said that.
Yeah, I was just going to say, I think that the expense also comes into play though with salary, and it's cheaper to employ a CRNA than it is to employ an anesthesiologist. I mean, I think I agree with the overall statement that the system of oversight works well the way that it is. Sounds like this is happening whether we approve or disapprove it anyways. I think having oversight makes sense. I worry with some of the comments that I think Margaret had made, and Ian and Evan, that by formalizing this, we may in fact create some regionalization where a hospital decides they're not going to have an anesthesiologist. And, it's absolutely appropriate for CRNAs to be more selective about their cases and do things that they feel comfortable with, which is only going to push more of the procedures to the larger hospitals, which we already know that UVM has a giant burden in this state, and to some extent Dartmouth for that side of the state as well. And I can see where if more states, say CVMC, decides to get rid of their anesthesiologists, they're going to be much more selective in what procedures we can do here. And I can see that pushing some of the procedures across the way. So I think there are ramifications besides just purely monetary and quality that we have to look at from an entire systems procedure process. Any more discussion? We do have a motion on the table. Suzanne?
I was just gonna say, I agree with everyone's comments, and what we can't do is look into the future and what's gonna happen in 10 years, 5 years. And I know that, David, you mentioned it's gonna go through anyways, but I still think that our voice opposing would be a good thing.
Oh, I definitely think you should vote your opinion.
Yeah. And to be clear, I've worked at a critical access hospital that had only a CRNA, and it was great to have them because it was that or not, but nobody. And they did a great job with what they did, but we were super selective about what they would do. And it was basically minor procedures. Basically, I could count on them to do anything that I could do. And then, they would cover for emergency C-sections, and that was about it. We just did not do much. And they understood that they had a very narrow window. Now, some are certainly much more trained to be able to do more, but I really think we can't focus enough on how well the teamwork between having a CRNA and an anesthesiologist, and covering multiple ORs, but having one CRNA. I mean, it's the perfect team, really. And I think that we should be promoting that more than, just one or the other.
But that is my issue too, is because if the CRNA are only doing the minor cases, who does the complicated cases? Everybody's gonna go to Boston? I don't think so. You'll be dead by the time you get to Boston. So who does the case here in Vermont?
Right.
I mean, there's other things we need to think about.
Yeah. Don?
No, I'm trying to process all this. But it sounds like, first of all, if it ain't broke, don't fix it. But it also sounds like there's going to be a lot of disruption in the system and the balance of cases, and a lot of kind of perverse incentives built into this that might lead, as Suzanne said, not tomorrow, but in a few years, to some shaky outcomes in the tertiary care arena. So I think our voice should be heard.
Agreed.
Or expressed.
Yeah.
Call the question.
Second.
Who is that?
I said, call the question.
Oh, thanks. Yes. All those in favor of the motion? Aye.
Could someone
Aye.
repeat the
Aye.
Okay, yeah.
Sorry, Don, did you need clarification?
Well, could someone repeat the motion, please?
So the motion is that we are not, as a organization, as a board, we are not in favor of reducing the,
Okay.
what the exact word is on there is sorry, I'm trying to find the exact
Opt-out.
wording for you.
Opt-out.
The opt-out. We
Okay,
are not in favor of supporting the opt-out clause for CMS.
okay, thank you, Matt.
So we'll go back again. All those in favor, aye.
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 Any opposed? Any abstentions? Motion passes. Okay, we had one last thing on the agenda, I believe, the test to treat. Do we need to discuss that today, David?
I haven't, I mean, it was in the, like the CRNA opt-out, it was in the application for the Rural Health Transformation Grant, and that, it was announced that Vermont got the $195 million grant. So I would So you can all read the tea leaves on which way that one's likely to go. It said it's something that would be pursued. That one is a little bit different. I don't know that it requires legislation. It probably doesn't, only because a few years ago, the law was amended to provide a system for protocols for what's referred to as clinical pharmacy to be proposed and then subject to the approval of the Commissioner of Health. So I think that there could be additional protocols proposed, which would probably come out of the Board of Pharmacy and OPR. And then the health department would have to approve them. So I don't know that it's going to come up in a bill, and nothing has come to me yet saying this is going to be acted upon immediately. I don't know. I'm going to ask Jessa. Usually has information about these issues in advance. I don't know if Jess has heard anything. I'll ask her for.
Okay. Why don't, I'm going to suggest that we defer this then for any further discussion until we know what exactly we're dealing with, what kind of issues and what kind of approval they may or may not need. Evan?
Jessa, have you heard anything?
I have not heard. I've definitely.
Oh, sorry. I
heard
thought
that
Jessa
sorry.
came off. Sorry, I thought you dropped you.
Oh, no problem. Still hanging on. Appreciate the discussion. I have not heard this coming up imminently. I definitely know there is continued interest. My read of the state statute is there is a enumerated list in statute of the protocols that are allowed. So the way I've been reading it is there actually would need to be an addition of whichever additional protocols are desired. I could be wrong about that, and maybe it could go straight to protocol. Either way, I think there will be further process, and we haven't heard about it like starting imminently. I would expect it, in the next couple months.
Okay.
Could we get a list of what's allowed currently?
Oh, I can send this. I'll send the statute out to everybody this afternoon. A copy
Great.
of it.
Okay, that'd be great.
Are there
So are you saying-
regulations too, David?
What's that?
Are there regulations that go along with the statute? Rules, I mean.
I don't believe that rules have been passed. I'd have to check
Okay.
to make sure that
Because sometimes the
This-
details are in the rules.
yeah, the statute lays out with a little bit more specificity than you sometimes see in statutes about the process for the protocols to be established.
Suzanne?
Okay.
So quick question, just so we think about this for if we talk about it next month. Because the money has already been allocated, does that mean this is just, it's gonna happen? Or is it still gonna be up for discussion?
Well, it's interesting that the Vermont submitted an application for the grant. There are scoring criteria that mentioned these different items. The money has been awarded, but it hasn't been drawn down yet, obviously. I don't know if they're going to come back if Vermont says, oh, wait a minute, we said we were going to do that, but we've realized that it wasn't a good idea. I don't know what would happen if they would try and reduce the grant amount, withhold some of the funds. I don't know.
Suzanne, I can say I've been in a couple of meetings about this grant already, and it's a bit chaotic. And there's a lot of discussion going on about where this money is going to go. And there's like a timetable. If you don't spend it within the year, you lose it. So there's a ton of pressure to spend a lot of money very quickly.
Which drives bad policy usually.
Which
right?
drives
Yeah,
bad
which makes
policy.
me very nervous.
So,
Yeah,
Yeah.
there's a
I-
lot of good. I've been in meetings and heard some really good discussion about how we can improve healthcare in the state of Vermont. So in that respect, I'm hopeful, but the process feels very wrong.
Mhm.
Yeah, I'm totally pro if they're gonna push more immunizations and all that, but the test to treat makes me a little nervous.
Agreed.
yeah.
I'd like to know the details. I mean, it's a big difference between patient is healthy, thinks she's pregnant, wants to be pregnant, has a pregnancy test, and is advised to take prenatal vitamins by the pharmacist versus someone comes in, has a positive COVID test, wants to take Paxlovid, which has a ton of drug interactions, and their primary care really should know. It's just very
Yeah.
different. And what you're describing sounds a lot like when the state psychiatric hospital closed with the flooding, and there was a sudden chaotic free-for-all of everybody trying to grab money, saying they could take care of those patients on an outpatient basis, and it was terrible. So I think we should be looking into this as quickly as we can and at least formulating, where we stand.
Yeah, and if I can, so the memo that I sent out last week, it's on page 7 is the statute about clinical pharmacy is summarized, and it has the citation for the section, and Jess is right. The list doesn't include test to treat. The statute would have to be amended to put test to treat as a category of situations that are authorized for protocols, but that's probably the way this would take shape. And so I think in the discussion, if the board was going to be against it, you like specific examples of bad situations, I think would have to be dealt with at the protocol level, I think, as opposed to the broader level about test to treat being okay. That's my initial read on it. If you see what I'm saying, that there are, and Peter responded to my memo and pointed out like some specific drugs where it's like it's really problematic to test to treat based just on the test result, and could be very dangerous for patients. But there may be some situations where it's appropriate, and so I think we need to focus on the broader situation than the specifics, because the way the statute is set up now, I think the framework is built to screen out the bad situations at the protocol level. If you see what I'm saying.
Judy?
I also just wanted to express a concern that this could influence pharmaceutical companies. It could tempt pharmaceutical companies to pressure pharmacists to test/treat in order to sell more medication. And I would hate to see, I think that would be too tempting for the pharmaceutical companies.
Dawn?
Well, first of all, Judy, you're implying that the pharmaceutical companies respond to economic incentives, and we know that's wrong. So procedurally, are we going to talk about this further? Because in David's write-up that he sent out a couple of days ago, I have a very specific question about a couple of sentences, and I can hold off on that if we're going to revisit this in a month. Otherwise, I'd like to talk about it now, but I don't know what the plan is.
I think we don't know what we're talking about totally. So I think it would make more sense to hold off any further discussion because
Okay.
we don't
Thank you.
really understand the situation, I think.
Okay,
Peter?
thank you.
Yeah, if we're gonna hold off, that's fine. I had a few thoughts of, the program versus the protocols, but I'll table it. It's cool.
Evan?
I'm looking, I did read the things, David, that you sent minus the one from today, and somehow I blipped over this. But with the ones that they're mentioning being flu, strep, UTIs, and COVID, there are some real problems embedded in that sentence. And if there's any possibility that this is going forward quickly and we need a supplementary meeting to discuss it, then we should have one.
Yeah, I agree.
I think that makes a lot of sense,
agree.
Evan.
Yeah, I agree with that too. UTIs, most UTIs don't even need to be treated, even in the hospital now. Our ID doctors are really on us that, we are creating a lot of antibiotic resistance that we don't need.
Right.
And flu and COVID are not that simple. This is not a checkbox prescription.
Yeah,
People
there's
are
even a
testing
question
at home
about
for
treating
those
strep.
now. Right.
Yeah. So why don't we do this? Why don't we let David get a little more info, find out what exactly the discussion is at hand and what needs to come from the board. If it can wait
Perfect.
until our next board meeting, we will do that. If not, we will gather between now and then.
Okay.
David, are you good with that?
Sounds
Will
good.
that satisfy what you think you need?
Yeah, that sounds good. I'll send out an email on trying to schedule an emergency meeting. If we know we need to, once we know what we need to deal with. So,
Okay.
And again, that the most likely scenario will be a bill gets proposed and taken up quickly, that puts test to treat into the laundry list of clinical pharmacy modalities, which is in Title 26 in the pharmacist sections.
Okay. And you'll send us out that info?
Yes.
Okay.
Yeah.
All right. Are there any other discussions that we need to discuss today? So I'd like to propose that we adjourn, but I do want to say thank you to everybody. This was a long meeting with a lot of intense information. I appreciate everybody's input. I appreciate everybody that kept me in line today. If you notice things like that, please point it out.
Did a great job, Matt.
Thank you. So, motion to adjourn?
So move, Philibert.
Second.
Thanks to
All right.
Paula. Thanks to
Thank
Matt.
you.
Thanks
See
to
y'all.
David.
Be well,
All right.
Paula.
Yeah.
Good
It's
luck.
Thank you, everybody. Yeah, good luck, Paula.
Thanks, Paula.
Yeah,
Bye-bye.
Paula, that's
We'll
right.
miss you.
Yeah, for sure.
Always.
Thank you.
She's already got her coat on. She's already out the door.
Yeah, I'm good.
Okay. Bye-bye now.
Bye.
Bye-bye.